talking about the current concept of visual fields. The most important factor in the visual fields is the proper evaluation of the disc. This patient is seen in 2012, inferior rim defect with the arcade defect and open angle, asked for visual fields. The visual fields is showing upper arcade scotoma corresponding to the arcade defect and the nerve fiber layer defect, and started on treatment in 2012. And this patient is followed up to 2014. In spite of the patient not taking properly, there is no much gross progression, and the mean deviation change is only from 9 to almost 10 to 12, but the change can be attributed to the high fixation losses. So if you think carefully, it is a tilted disc. Tilted disc is producing the nerve fiber layer defect and causing the field defect. So the most important is the proper evaluation of the disc, and visual field should never be interrupted in isolation. It should always be correlated with the fundus picture. Now I start the talk. The plan of the talk is understanding of single field analysis printout and then interpretation of the probability plots. So the most important thing is we have to understand each component meaning in the single field analysis printout and the interpretation of the probability plots to diagnose glaucoma, to set the target IOP, and now we can classify glaucomas on the basis of visual field defects and the progression analysis. Now I briefly talk about the understanding of single field analysis printout. For better understanding, the single field analysis printout is divided into zones. This is the patient data, test data, the reliability data, raw data, grayscale, probability plot, total deviation probability plot, and total numerical deviation numerical plot, and the total deviation probability plot, pattern deviation numerical plot, and pattern deviation probability plot, global indices which contains mean deviation and the PSD, and the glaucoma hemifield test. So we have to understand each component of the single field analysis printout. So the patient data is what we feed to the computer. The name of the patient, age of the patient, the visual acuity, visual field correction for near vision, and visual acuity is very, very important. And for evaluation, we have to correlate the visual acuity and the foveal sensitivity. Then we know what the near vision correction is given is correct or not. Age should be entered properly. And always then the test data, whether we selected 24-2 or 10-2, what strategy we want, whether we require SETA standard or SETA fast, and always the size of the stimulus is always size 3. And coming to the reliability data, now how the patient did the test, the false positives, false negatives, and fixation losses. The slope of the indication of the slope. If the slope is regular, the PSD will be minimal. If the slope is irregular, the PSD will be significant. And the glaucoma hemifield test is the software that developed to pick up the localized scotomas, to pick up early glaucoma. With this basic understanding, we go now, if you understand, what do you understand by a 0 in raw data? What do you understand by 0 in total deviation numerical plot? What do you understand by pattern deviation numerical plot? A 0 in raw data is absolute scotoma. This point won't respond to the maximum intensity of light that is projected by the perimeter. That is 0 dB. 0 dB in a raw data is absolute scotoma. 0 in total deviation numerical plot, that means there is no loss from the normal. There is no deviation from the normal. That means this point had normal retinal sensitivity. A 0 in the total deviation, pattern deviation numerical plot indicates the 7th best point of the corresponding point of the total deviation numerical plot. So if you understand what is zero in raw data, what is zero in total deviation numerical plot, what is zero in pattern deviation numerical plot, if you tell correctly, that means you have a good concept of the visual fields. Then coming to the interpretation of the single, actually the interpretation of the single field analysis is a broad term. Actually we interpret the scotoma. Always we start the interpretation, interpreting the probability plot. So the correct terminology is the interpretation of the probability plot. The art of coming to the interpretation is always eliminate the artifact. It is an art, because a black square in the probability plot can be produced by if the pupil size is small, the refractive error correction is not proper, then fixation losses, then false negatives, rim artifacts, and the position of the lid. So you should develop the art to pick up and identify the artifact. So in this case, this patient seen in 1997, diagnosed as advanced glaucoma. When I saw this patient and following, and 91, almost the fields were normal. And this mistake was done because the fields were taken in a very small people. And this patient is taken with the field without correction. And I know this patient had a 6/6 vision. See, the retinal sensitivity, the people at the foveal sensitivity is 25, because the field was taken without correction of -7 myope. He had a uniform total depression, and when the correction is given, the fields became normal. So the most important thing is visual acuity and the foveal sensitivity. If the patient is having 6/6 vision and the foveal sensitivity is 25, that means the refractive error correction was not properly given to the patient, and he had a uniform generalized depression with a normal pattern deviation probability plot. So this patient, the June is taken in June 2015 and 2016. If you see, the mean deviation is 25 and the mean deviation is 16. Even though the false, here if you see false positives are 0 and false fixation losses are 0 in both, and the foveal sensitivity is almost only 4 dB change is there, but there is a huge, and in spite of fixation losses of 27 and fixation loss of 16, the mean deviation should be more in this case here, but this is more. Why? Because if you see the raw data, usually we see a inferior less sign in front of 0. But here we are appearing as an inferior sign in front of a digit, it is sensitivity 1. So it always, when it is there, it requires the cleaning of the machine or recalibration of the bulb or changing the bulb. So the most important thing is you have to see the raw data. That means the maximum light of intensity is not projecting. It should be 0. And it is not projecting, then the 0 won't come. Then this number will come. And that is why here, even though the fixation losses of 21, it is coming more, magnificent, coming high. In this case, the patient is seen in 2014 and 2015, and it improved like in 2015, improved like drastically. But if you see the fixation, the only difference is between these two is, in 2014 printout, the fixation losses are 0. In 2015 case, the fixation losses are 2. Then which is correct? If you see the retinal sensitivity, here it is coming 0, here it is normal. If you want to know which is correct, we have to go for 10-2. If you take 10-2, that means it is corresponding to the 2014. So even the 2% fixation loss difference, it is the 2 fixation loss is producing huge change in the visual field printout. Therefore, there is nothing like which is we can accept up to 10% or 20. It is not like that. When you are suspecting, try to be, when in a known case or established case, these parameters doesn't have much value, but in a suspected case, even 1% or the ratio you will have any great impact. So how to avoid these artifacts? We have to proper education, repeat the test with fast strategies if the patient is not able to do with SETA standard. Nowadays we are not doing any fast pack or standard threshold, it is only either SETA standard or SETA fast. Change the fixation sometimes from small to big diamond, or change the stimulus size from 3 to 5. So with that, the most important art of perimetry is picking up the artifact. With this good knowledge, now we will proceed. Usually I used to give the talk as a suspicious case of glaucoma, interpretation of visual fields, a suspicious case of glaucoma, early case, established case, advanced case, glaucoma associated with cataract, and assessment of glaucoma progression. This time I am changing the routine talk because they told the topic that is given today is the current concepts of visual fields in the management of glaucoma. This case is the glaucoma suspect, the field. Usually most important thing when you suspect glaucoma and having a scotoma, the most important thing is elimination of the artifact. That is the most important approach in a case of suspect. First of all, when you see a scotoma, whether it is a real scotoma or not, if it is a real scotoma, then it applies to Anderson's criteria to diagnose a localized field defect that is the size of the blind spot. Here, what is Anderson's criteria? Anderson's criteria is nothing but to pick up an early localized scotoma which is supposed to be glaucoma, and that is why you should have a cluster points 3 with 1 point p-value less than 1% and 2 points p-value less than 5%, and PSD will be less than 5%, GHT outside normal limits, and usually we don't consider the outer set points of 30-2. Exactly what do you mean? Sometimes this means the glaucoma starts here and progresses. This starting point will have a p-value less than 1%, and these 2 points we can have p-value less than 0. When this irregular scotoma, PSD will be automatically significant, and glaucoma hemifield test usually will be abnormal. So this is to say Anderson's criteria. In this patient, the suspected glaucoma between disparity of the cups, and the visual fields were taken, and with fixation losses 1, false positive 7 and 3, diagnosed as glaucoma, started the treatment. But if you see carefully the disc, it is actually a cup disparity, and the discs are big and the cups are corresponding to the discs, and the fields were taken with 0, 0, 0, the scotoma disappeared. So the most important thing is when you suspect glaucoma, the reliability factor should be 100%, try to be 100% perfect. In this case, glaucoma is suspected. This is looking normal. If you see both the discs, this disc shapes are different. This is more vertical and this is more round, and there is a vertical cup. You always remember one thing. When there is a small disc, even if you see a cup, you always suspect glaucoma. That is a very, very important point. You remember this disc with this cup. You see a number of cases like this with field defects, and the field were taken. This is the field. Suppose if this field is there, we usually think that it is not glaucoma. But if you see this field, sometimes this can appear like this because it's very, very, very early. And the most important thing, the observation what we have to do is, almost this is the nasal step and almost it is appearing here. This scotoma in this area almost appearing here. That means the changes are occurring correspondingly. This is the very, very important thing to pick up early glaucoma. So, when I see a suspicious case of glaucoma, fundus evaluation and interpretation of the field defect must be very meticulous. SETA standard should be the strategy. Reliability indices should be 100% perfect. Don't hesitate to take the second opinion. Interpret OCT with care. take enough time to start anti-glaucoma treatment. Now coming to the almost early case, and this time I told you the concept of visual fields and the classification of visual fields on the basis of the classification of glaucomas on the basis of visual fields. Normally we classify glaucoma as a POEG on the basis of IOP as a POEG, and if the tensions are normal as NTG. But this time my concept is we have to classify on the basis of visual field and field defect, where exactly the field defect is starting and how it is progressing. The field defect starting outside 10 degrees, the field defect starting within 10 degrees, or the field defect starting simultaneously in both 10-2 and 30-2. Suppose the field defect starting outside 10 degree circle, and you see the progression, how it is progressing, whether it is progressing towards fixation or away from the fixation following the arcade pattern. So in this pattern, I will be presenting the cases. First we start with the glaucoma starting outside 10 degrees and following arcade pattern. This patient there is no doubt about the glaucoma. It is a known case of glaucoma. Pressures are high, and the most important component what we understand is the pattern deviation probability plot is created not only for to identify localized scotoma in the deep generalized loss. Even in this case also, we can know the progression of the field defect in the pattern deviation probability plot. That is a very, very important. The pattern deviation probability plot gives you the direction of progression. Here actually the deep scotoma started here. In this we do not know where it started and how it is progressing. If you see the pattern deviation probability plot, we can identify it is started here as an upper arcade scotoma and progressing downwards, and it is following the arcade pattern. And when for this management, always you see a black square in the probability plot doesn't mean it is absolute scotoma. It only indicates the loss of retinal sensitivity is more than 5 dB or 7 dB or 8 dB. That means it has a p-value of less than 0.5%. Any deviation value that means more than 7 or 8 dB will have a p-value less than 0.5%, and it is represented by a black square. Black square only indicates at that point the deviation value is more than 10 dB. So still the patient have 25 dB sensitivity, still it is a black square. So a black square is not an absolute scotoma. So from this you decide this is not a severe glaucoma. So your treatment need not be very aggressive. So whenever you see a glaucoma, always see the probability plot, then see how much loss is there, how is it progressing, and what is the residual retinal sensitivity, and then plan the drug to control IOP. The same the other eye, actually this is started here and progressing up and down, and always follow the same thing. What is the deviation value, what is the residual retinal sensitivity, how is the retinal sensitivity on the 3 degree circle of 24-2, and decide the treatment. This is also a case starting outside 10-2 as an arcade pattern and progressing away from fixation. And always see the retina, what is the corresponding retinal sensitivity and what is the loss, how it is progressing, and you decide the treatment. Now, we see the cases starting the glaucomatous damage outside 10-2 and progressing towards fixation. Known cases they're all known cases. Here if you see the disease, we do not know where it started and how it is progressing. If you see the probability plot, that means actually the disease started in upper arcade and producing in both the directions towards fixation, and you see it is progressing and the deviation values are high. Always get the habit of seeing the raw data and the total deviation numerical plot. Don't end at the probability plots. If you see the probability plot, it's the probability plots, that's all. If you don't get any information from the probability plot except we know how it is progressing and what is the extent of the field effect. Only extent and the progression of the field effect is only known from the probability plot. If you want to know the exact retinal sensitivity and exact loss of retinal sensitivity and how it is progressing, what is the sensitivity around the fixation, we have to get the habit of seeing the raw data and the total deviation numerical plot. If you see this case also, the upper arcade started here, progressing towards 10-2. So, and in these cases, we have to be little more aggressive. This also, if you see, this case started as an upper arcade. This patient started in an upper arcade and is not coming down. It is going towards fixation without, it is coming only the last started now. And it is going towards fixation and almost it is involving the 10-2 almost up to fixation. The same thing also, this is started upper arcade coming down and going towards fixation. So the glaucoma's field effects starting outside 10-2, there are two categories. One is not progressing towards fixation and one is progressing towards progression. Now we will see the glaucoma starting in 10-2 and 24-2 almost normal, predominantly in 10-2. If you see this case and first time present in the OP, almost normal, and because the glaucoma is suspected in this case, glaucoma is suspected in this case because of the notch, and this I saw later in the fundus photograph. Started and the fields were taken. If you see 24-2, I asked for 24-2 as usual, and 24-2 has the picture like this with a mean deviation of -9. And always, suppose if you take 24-2, but there are norms, always follow the norms. What is the, if you see almost coming up to fixation, always you see what is the retinal sensitive value of on the 3-degree circle. If it is on the lower side, even if it is 5 or less than 10, you ask for 10-2. If the 10-2 taken, this means exactly usual the disease started in 10-2 actually and spreading towards, in this case the mean deviation is 12. This is a very, very important. If you miss, if you don't take 10-2 and if you see only 24-2 in the follow-up test, you assess the progression in 24-2 and you lose the progression of 10-2. So this is the disease. So most important is examination of the, here if I suspected 10-2 because it is going almost near the fixation. It is coming almost near to, so the last sometimes will be like this, the last sometimes coming like this. It is coming like this, sometimes the last comes like this. The other eye you see, still more dangerous. Almost it is, even in 10-2, they are following the arcade pattern. There is no blind spot, but they are following arcade pattern. And with a mean deviation of -18, they are almost becoming, if it progresses, it is, that means the fields, peripheral fields will be normal. That what we say peripheral field means 24-2 and 30-2, the 10-2 will almost become blind. This is another, once you know these cases exist, you will look for it. Because all these cases I picked up in the last 2 years. I picked up more than 50 cases. And I am presenting only few. And this patient, if you see, the nerve fiber layer defect is coming just like this. And this is the field. This means this glaucoma started in 10-2 and is progressing towards the 24-2 area, outside 10-2 area. In 10-2, and this patient is followed, and in 2012 with a mean deviation of -7 and -5, and the right eye is progressing. This is the mean deviation is 9. It came from 8 to 9. It is progressing, and 24-2 is almost normal, still more progressed. It is progressing. That means I have to keep the pressure still more low, and I have to do trabeculectomy if needed to keep the pressures very low. So the most important concept is glaucomas, what we usually speak, the nasal step or upper or the enlargement of the blind spot, all these things, when the glaucoma is starting in 10-2, there is no blind spot, there is no nasal step. So the most important thing is evaluation of the disc. The glaucomas, they can only these glaucoma. I am talking about open angles. All visual fields is meant for open angles. And these glaucomas, where the 10-2 they start, the tensions are very low. The tensions are not high. There are 13, 14, 15. So what we call NTGs, they are all the glaucomas. When you see a cup in NT with a normal pressure and you are suspecting 10-2, you always ask for, and you are suspecting glaucoma, you ask for 10-2. Now I will talk about the cases glaucoma starting simultaneously in both 10-2 and 24-2. This is the third component. If you see this patient, they started in they are isolated scotomas, started in 24-2, started in 10-2. So in progression, we have to go for both. How it is progressing in 24-2, how it is progressing in 10-2. This is another patient. It started an isolated scotoma in this, which is corresponding to that 10-2, and a lower arcade scotoma. It had two components, isolated components, simultaneously starting. Suppose if you take here, if you see the retinal sensitivity, the retinal sensitivity is about 13 or 11, and don't miss to take 10-2. If you see a black square, that means here I am not able to see. Then you see this patient. I told you, I told that suspected glaucoma where I showed corresponding changes. The disc of that patient and this patient is looking almost similar. In that patient, we have not seen nerve fibrillary defect, but here we can see the nerve fibrillary defect. And the disc is almost symmetrical to what we saw in the suspected case, the named Mangatayaru. And in this case, we see a broad nerve fibrillary defect, and you see the disc. And when the fields were taken, this is the right eye, and there are isolated scotomas in 24-2 and an isolated scotoma in 10-2. And if you see, the most important thing what you have to observe is these scotomas are coming from 10-2 area, and it is not progressing like this. You see, the progression is not like this, these scotomas are coming from 10-2 area. So whatever the scotoma you see in 24-2 does not mean that they are coming from the nasal step or from periphery. They can appear and progress even from 10-2. So the most important thing component, what we have to see is how is the progression. The 10-2 is progressing like this, 24-2 is progressing like this. And mostly it is the horizontal pattern, not taking in upper arcade or lower arcade. This is a dangerous situation. And if the patient develops like this in the lower side also, the patient was going to have a severe visual loss in no time. And still the mean deviations will be very normal. Now we are dealing the cases simultaneously occurring in both 10-2 and outside 10-2. You see isolated scotomas of 24-2 and isolated scotoma in the 10-2. So don't think that the glaucomas, they appear in 24-2 and progresses towards fixation. It is not like that. Glaucomas, they can start anywhere. So meticulous fundus examination is very, very, very important. In this case, if you see, this is also normal. The glaucoma is suspected only because of the disc hemorrhage. And if you see a disc hemorrhage, you always search for the arcade field defect and the nerve fiber loss. And there is a nerve fiber loss. The tensions are all normal, NTG, and the visual fields were taken. This patient also, if you see, there is a scotoma in the 24-2, but the scotoma is not corresponding to the field defect. The upper, this scotoma should be in the lower side. Therefore, there is a predominant upper arcade defect also, which we are not able to pick up in the fundus. See, the fundus, but the notch is there, you see, but we pick it up because of this. And so, that corresponding to the 10-2. So, if you see the arcade, it's almost in this picture, it's not like that. If you see the real, it is coming like this. It is coming towards the fixation, 10-2 area. So, this case also, there is started in 24-2 and 10-2. In 24-2, it is an upper arcade, in 10-2 is a lower segment. So, in this case also, see, corresponding isolated field defect is there. So I told you, if you see a small disc, be careful. A small disc and with a nerve fiber layer, and if you see the huge field defect coming towards fixation, upper arcade, lower arcade, coming to the fixation, and the field defect started in 10-2 and the spreading. So if you see this fundus, you can't even imagine how much glaucomatous damage is going on. So, but if you see the nerve fiber layer defect, it is huge nerve fiber layer defect. It is huge. And they are corresponding, how dangerous situations these are. So with this concept, now that is the current concept of visual fields. Now we come to the glaucoma associated with cataract. It is the most important clinical what we want. There are two clinical situations. Known patient of glaucoma coming with cataract, or a patient coming with cataract, we suspect glaucoma. Suppose if they are coming with cataract, you suspected glaucoma, your pure cataract will have a generalized field defect. If it is associated with a localized scotoma, glaucoma, it should have a localized scotoma in the generalized depression. To identify, actually the pattern deviation probability plots are created only to identify these scotomas in the generalized depression. So if the patient is having, suppose if this patient, black square only indicates the deviation loss is more than 7 dB or 8 dB. So if it is more, any cataract will produce a generalized field defect, and the loss is only minus dB at all the points. Suppose if this patient develops a localized scotoma here, the probability plots won't change. Already they are black. So to identify this localized scotoma which developed in generalized depression, the pattern deviation probability plots are created. How they created, I wrote the book, The Seventh Best Point. They identify the seventh best point and they add the retinal sensitivity that converts seventh best point to 0 is added to all the points. That means we are removing a generalized depression, the value of seventh best point. And once you remove a generalized depression, if you see a scotoma, that scotoma you again see, analyze as usual, whether that corresponds to the glaucomatous field defect or not, and said, in these both the cases there is no localized field defect in generalized depression. Therefore, there is no scotoma, it is a pure cataract. In this patient, the glaucoma is suspected in the case of cataract, and there is a generalized depression with a localized field defect in generalized field defect, and it is following the pattern of the where you suspected upper arcade, and then see what is the depth of the scotoma, and what is it a relative? The relative scotoma also can produce nerve fiber layer defect. If it is the relative scotoma, the tensions are not high, then you can have a clear corneal approach, do cataract, and then follow. If needed, you put on medical management. You consider what is the age of the patient. For all the cases of glaucoma with cataract, you need not do combined. You always assess the field. What is the field? If the field is not very high and the tensions are not very high, you approach, and the age of the patient is more than 70 and all, still you can have only pure cataract extraction, clear corneal, and preserve the conjunctiva for future trabeculectomy. So the important thing is, even in a case of cataract, and the glaucoma analysis. What is the field defect? What is the extent of the field defect? What is the depth of the field defect? How it is crossing? You have to follow everything and take the decision. See, this is the suspected, but here there are relative scotoma here, relative scotoma producing. Now coming to the progression analysis. There are two clinical situations. The patient coming to us, our own patient for follow-up, already carrying the printout of our visual field analyzer, or the patient coming with a printout with somewhere and come. There are two clinical situations. So, if already the patient is seen somewhere, having the printout somewhere, and you take the printout, you don't get the overview printout. You have to analyze the single field analysis side by side. If the patient is having this printout seen by us, taken by the perimeter, if you have one perimeter or two perimeters with you, analyzers, you have to write on this, on which analyzer the printout is taken. And for when the patient is coming for follow-up, the patient should be subjected to the same field analyzer. Otherwise, you don't get the overview printout. And you should be very meticulous. The data, how the patient entered in the previous name of the patient, you should be highly meticulous. Even the spacing of the letter should be perfect. The date of birth should be perfect. If you write the date of birth different, then you don't get overview printout. So it should be properly entered, and we will get the overview printout. So we need not have two printouts. This overview printout, the single field analysis printout data, all the data is incorporated in this overview printout, except the total deviation numerical plot and pattern deviation numerical plot are absent. Even the PG students in DNB exam, they may ask, which components are absent in the overview printout? It is actually total deviation numerical plot and the pattern deviation numerical plot are absent. It has the patient data, test data, the grayscale, raw data, probability plots, fixed reliability data, mean deviation index, PSD, and glaucoma hemifield test. All the components will be there, except total deviation numerical plot and the pattern deviation numerical plot. So when the overview, to get the overview printout, it should be either 24-2 and 30-2, you will get the overview printout. If you have a 24-2 and 10-2, we don't get the overview printout. We have different single field analysis printouts. Now, the most important component, the PSD. In the single field analysis case, in the glaucoma, PSD has only value in two situations. In a suspected case of glaucoma, that's all. Once it is an established case of glaucoma, there is no role of PSD, because it only tells about the dip. And if a dip starts, that means a localized scotoma to pick up early glaucoma. Once early glaucoma starts, the irregularity starts. How much irregular it is all not very important. But the PSD again has a role in progression. So, a mean deviation index. If there is a change in mean deviation index is there, we say there is progression. So, no increase in mean deviation index means no progression. If there is an increase in mean deviation index, that means there is an increase and the progression is there. And you see PSD, if there is no change in PSD, that means there is no irregularity. The loss is uniform. There is a uniform loss, usually due to cataract or any other causes which causes uniform loss. So, there is a value of PSD in progression analysis. And if the significant change in PSD, which indicates there is a localized loss. So, before coming, there is to say there is an increase in mean deviation, we have to see all these things. What is the point pattern between the previous test and the present test? What is the visual acuity of the previous test and the present test? What is the foveal sensitivity? Suppose if the foveal sensitivity of the previous test and the present test is not similar, we have to assess that change may be due to this proper irregular correction, not properly given correction. What is the reliability data? How are the fixation losses? What are the false positives? What are the false negatives? What is the size of the people? All these things should be considered before telling there is progression. See, because even I told you, 1% fixation loss, how much change is there between the fields. So in this case, I am showing the two cases. So change in mean deviation index. This is a very important concept. Change in mean deviation index. A change in mean deviation index in a localized case of glaucoma, a change in mean deviation index in a generalized depression. This is a very, very important concept because we are considering change in mean deviation. Suppose in this case, it is a case of localized field defect. And the localized field defect is here, and the loss is occurring here. Suppose the progression is occurring here. When it is expressed in terms of mean deviation, this is the mean of all the points. It is the mean of all the points. This change is distributed to all the points and will be expressed as mean deviation. So, a change in mean deviation in a localized scotoma, even if it is 4, it is not actually 4. It is huge. It is confined to one segment. It is huge. It is confined to 2 segments. Little less, it is confined into all the segments. That means that is true index. So change in mean deviation, whether it is a true index or so, you should know. A change in mean deviation, immediately you should ask, what is the extent of the field defect? If the extent of the field defect is confined to one segment, confined to a few points, that change is huge. So in a localized scotoma, say if the mean deviation change is 1 dB, we have to consider it is huge. Now, in this case, there is a generalized depression. If the change is occurring all the points and is expressed as a mean deviation, that is a true index. So, the concept of change in mean deviation in a localized scotoma, so straight away don't see how is the change, how much is the change. We have to see the extent of the field defect. So, the extent of the field defect is very important. The change in mean deviation in localized scotoma, change in mean deviation in generalized depression. So 2 dB change in a localized and 2 dB change in mean deviation index, they are not identical. This patient, the mean deviation is changing almost similar. See, in this case, this is a localized scotoma here. When the follow-up test, they disappear. This disappear is mainly due to the false the fixation, the false positives. The false positives are high. When compared to this, the false positives in the first test is 1 and here it is 13. So this is responsible. Actually in these things, the patient didn't improve or this thing. This is the correct field. This disappeared because of the false positives. So interpretation of the progression, you have to consider the fixation, reliability data, the size of the pupil, refractor correction, pupil size, then foveal sensitivity, all these things should be taken into consideration. And this patient, you see, and followed from, actually I forgot, I had the follow-up of the patient up to almost 2015, still in my follow-up. Now after the fields almost they are stable, but initially I saw this patient in 2003, 2004, 2006. That means the stage where I am learning visual fields. And in those days, in 2002, in 2000, if one speaks only if you can tell the terms, pattern deviation plot, or pattern standard deviation, mean deviation index, you are great. In 2000, you are great. And when I learned this thing, I was told, put a teacup on the grayscale. Put a teacup on the grayscale. So I was in that impression. I never concentrated, and I used to see only the probability plots. When I had this, even the probability plot, the concept of probability plot didn't sink into my mind. A black square means, in those days we used to think that it is absolute scleroderma. A black square in the probability plot only indicates the loss is more than 10 dB, that's all, not more than that. And if a black square appears in the probability plot, it won't assess, we don't know, the progression is of two types: vertical progression, horizontal progression. The vertical progression, once a black spot appears, the vertical progression cannot be assessed. We have to see the raw data only to know whether there is a progression or not. By seeing the probability plots are only created to know the extent of the field effect. And if you want to see the depth of the field effect, you have to see the raw data, and which I missed. And there is a change in mean deviation is occurring, -7 to -12. -7 to -12 in a localized scotoma, that concept I don't have. In 2003 and 2004, I don't have the concept. A change in mean deviation, even a small in a localized scotoma is huge. And almost a good retinal sensitivity almost became absolute scotoma. And if you see the grayscale, it is appearing. But whatever, always what you know you will see. What you do not know you won't see. So don't put a teacup on the grayscale. Grayscale is very, very important. Grayscale is very, very important. It tells us the depth of the field effect on glance. And that can be seen in the raw data, all total deviation numerical plot. So in this case, it is progressing, vertical progression. Horizontal progression is not there. Even if it is there, it is minimal. So you see, almost became 21 became almost absolute scotoma. In this case, I tell you another most important concept. This patient is having all absolute scotomas surrounding and few retinal sensitivity points. And these points, in suppose this for progression, the change in these points, only few 8 points are there. This change in mean deviation will be expressed in the terms of all the points. So, for progression, you have to see, even the absolute, it is distributed to the absolute scotomas also. And even a 0.5 dB change, will have a great impact, because this change of 11 points is distributed to 54 points or 56 points. So, you always see how many points are there, how many points are absolute scotomas. And in this case, actually, you have to go for 10-2 for progression along with the 24-2. If you say 24-2 is not showing any progression, still it is showing, because it had a few points, it is showing. The few points are losing huge retinal sensitivity. Even 0.5 means it is equivalent to 10. Like that. You have to see. You see, I told you, this patient, it is progressing in the 10-2 and 24- and 30-2 being normal. In 10-2 it is progressing. And you see the progression in the grayscale. See how beautifully you see appreciate in grayscale. Grayscale is very, very important. This is the, I told you, Swarnalatha, the patient with a huge scotoma is progressing in the, and they are following the arcade pattern in the grayscale. See, it is progressing, but this progression is not much in the 24-2 or 30-2. Thank you.